All right, welcome back everybody for our next presentation. Let's see, which one, so I want to remind you everyone this time. Again, YouTube is available for all of our previous presentations. I'll get Dr. Diaz up there here in just a minute. Remember your certificates of attendance, look for those. Those come out an hour after completion. And yeah, put your questions down into the chat as we go through. So our next presenter, Mr. Chris Ebright, is going to present to us now. I will turn it over to Chris and I'll let him introduce himself.
Okay, thanks, Sean. Welcome, everybody. Hopefully you're enjoying the day. And I know it's been kind of a long day, but we're going to give you something here. Hopefully you're going to be a little bit worthwhile to take with you. And that's a little bit about unfortunate event, which is called pediatric cardiac arrest. I know your previous session talked a little bit about cardiac arrest, mostly in adults. We're going to dive into a little bit more here with kids and some stuff to look out for. Before we start, though, just introduce myself. As he said, my name is Chris Ebright. I am currently the lead instructor for the EMS education program here at the University of Toledo in Toledo, Ohio. And I've been a medic now going on for 27 years. I've been teaching for about 26. And I've had the privilege of coming out to your conference, it seems like forever and a day ago with all the COVID stuff going on. But I've had also opportunities to go all over the country and speak to different people. And it's always fun to get out and see how the other half lives. So hopefully we'll be doing this in person sooner than later. If you have any questions, by all means, feel free to ask, and we'll try to catch them during the session. If not, I will put up my information at the end of this session, and you're more than welcome to get a hold of me through my website or through my email, and I will respond to you as soon as I get those, and hopefully can answer any questions you might have if we don't get to them now. All right. So that being said, let's go ahead and get started. When we start looking at the things we're going to talk about here, like I said, we're going to go a little bit over, excuse me, some reasons behind cardiac arrest. Fortunately, with kids, when they go into cardiac arrest, which is not a fortunate thing, the causes seem to be somewhat obvious. And also, fortunately for most of us in the pre-hospital setting, we can do something about the majority of them if we can discover them. So we're going to talk about those. We're going to do a little bit about taking our time on scene too, which is for most people kind of counterintuitive because they have a child, all they want to do is scoop and run. But what I'll show you is that actually doing just the opposite is more of a benefit for a child than scooping and running. We'll talk a little bit about also epinephrine and obviously delays in giving it and how bad that can be for your patient. We'll talk a little bit about PICC crew CPR. We're going to talk a little bit about some other causes like commotio cordis and long QT syndrome that could be the possible causes behind your child's cardiac arrest. And then also lastly, getting to a point where if you have a traumatic cardiac arrest, well, we know with adults that the outcomes are usually pretty abysmal just because it's a major anatomical disruption. And with children, it's not a whole lot different. However, there are going to be some things we'll talk about that you need to consider that maybe we keep going with these kids until we get them to the hospital because they still may have a chance. And we'll kind of get towards that at the end. All right. So a little bit of numbers here for you. And we start looking at numbers. Again, they don't really change, unfortunately, from year to year. So these statistics are about 3 years old, but if you look, the numbers really haven't unfortunately changed a whole lot. So we're looking at a little over 16,000 kids a year go into cardiac arrest, and of them, only about 5 or 10% are actually resuscitated outside of the hospital and actually go on to survive. The good thing is that, well, we do have that 5 or 10%, which is still a significant number if they're one of those 5 or 10%, but because of their downtime typically, and this is also with adults, but we see this even more so with kids because they're so much more fragile, that if they do survive, they end up with really severe neurological deficits. And as a result, this may be one of those children that you end up running on numerous times throughout your career because of those residual effects. The other thing is that, again, typically with you having a witnessed arrest, the sooner that BLS is started, and even sooner than that, if that child needs to be defibrillated, their outcomes tend to be very, very good. The problem is that most kids don't usually go into VTAC or VFib as their cardiac arrest rhythm. they're very predictable. They go very fast, they go very slow, and then they just kind of stop. And so the AED, if you put it on, or your defibrillator, if you attach it and look through the patches, is probably going to give you either a no shock advised, or it's going to tell you by looking at it that obviously it's a non-shockable rhythm. But if it is obviously defibrillated very quickly, then the outcomes are pretty good. Case in point, had a case when I was working down in Louisiana a number of years ago. Squad was called out to local high school for a child that basically had collapsed on the track. She got about 3/4 of the way around the track, kind of stumbled and then just collapsed. And her teacher runs over and sure enough finds her to be in cardiac arrest. The school did have an AED that was nearby. Students ran and got it. It was applied. And before the squad actually even got there, she was defibrillated on the field with good BLS and actually woke up and was talking as the squad pulled up, and she survived and she had no residual deficits. So speed was a good thing in that case, and obviously everything worked in her favor. Unfortunately, we don't have that, and time is usually not our friend in that pre-hospital setting. So if the outcomes are not good, it may be nothing that you did incorrectly. It's just that they were just down too long. All right, so let's look at these 7 different things. And the first thing that I kind of made up here is that, well, y'all can see it coming. And what do I mean by that? Well, if you look at the pediatric triangle, and some of you are familiar with this, and if not, well, there it is. There are 3 components of this that if any one of these 3 are abnormal, it can give you a pretty good estimate that there's obviously something wrong with the child and that they could be heading down to a major deficit, if not cardiac arrest. So their appearance, when you walk in that room, when you walk on that scene, what do you basically pick up on? What are you hearing? So on and so forth. So if they're limp and lifeless, parent runs out with the child in their arms and they're just kind of dangling, that's obviously never a good thing. Child's not interacting. So you walk up to them and they don't flinch. Most children, when you come up to them, they don't know you. And so as the closer that you get, the more they kind of cower towards their parent, their caregiver. They start getting upset, start crying, what have you. If a child doesn't do that when you get closer, in most cases, it's because, well, their brain's not really getting fed as well as it should. And that may be a precursor to some other bad things. Same thing if they're inconsolable. That's usually considered a very cardinal sign of an altered mental status, and usually, again, a perfusion and or oxygen issue with the brain. If they have any kind of abnormal looks, abnormal speech, cries, high-pitched cries, things like that, all of that can be an indicator that obviously something's wrong. And as I said, sometimes you'll hear that before you even see these kids. But when you do see them, what about their work of breathing? Do you hear any sounds that basically shouldn't be there? Grunting, wheezing, stridorous cough, crowing, croupy kinds of cough, things like that. Are they tripoding? Are they using accessory muscles, which perhaps when you don't see it right away, you pull up their t-shirt or whatever the case may be, and you see their rib cage kind of appearing and disappearing, or their sternum looks like it's being compressed by some kind of pair of invisible hands. Those are obviously things where the child's working with an extra effort to breathe, and because of that, they are in distress and need that assistance from us. Same thing when we get down to circulation. And now what we're looking at is mostly just skin itself. We haven't really put our hands on the patient yet, but do you see any abnormal coloring? Do you see mottling? Do you see a certain pattern of cyanosis, whether it's just at the face, or is it in the limbs, or is it full body? And the worse that it gets, obviously, the worse off that child probably is. So let's look at a few examples here. So you walk in, you see this child, and just by the appearance, she doesn't look very well, right? She's obviously looking somewhat tired. She's not paying attention to you as you walk in. She's drooling, as you can see there a little bit, and slightly tripoding as well. So all that would point to a number of different problems, but obviously she's doing all these things because she's trying to keep herself going and compensating for something. So we need to obviously assess her quickly and find out what those things are. Typically, the 2 big things that put down your adults put down your kids even quicker. What I'm talking about here is either hypoxia or hypovolemia. Either one of those 2 or a combination of both is going to be very detrimental to your kids. Now, how they get to this state is one part of the puzzle, but our part of the puzzle is how do we fix it? We take this little guy and we walk in, we can obviously see the cyanosis around his nose, lips, face, maybe a little bit even in the hands there, and that might be just part of a shadow as well. But kids shouldn't look like that. They shouldn't be cyanotic. And if they are cyanotic, well, they've already kind of been hypoxic and hypoxemic for a little bit. Now, remember, in contrast, kids burn through oxygen, they burn through sugar, they burn through a lot of stuff much faster than we do because their metabolism's so much faster. And it's one of those things that we wish we could have bottled when we were this age and kept it when we get into our later years. And maybe when I get into my age, like around mid 50s, and you could just re-inject it and get all that metabolism back. And man, it fixed a lot of my weight problems right away. So the same thing here. What they bring in, they burn up. They don't store a whole lot of stuff. And so when those reserves and what's in their bloodstream actually gets depleted, they get symptomatic very, very quickly. And they don't lie to you. I mean, this is what you got. What you see there, there's obviously something wrong. And it may be, again, circulation. It may be oxygenation. We can work on both. We take him. As I mentioned a little bit earlier, if you look at this little guy's sternum, okay, sternal retractions, you know, is not a good thing, but retractions in general, whether they're clavicular, whether they're intercostal, whether they're sternal, there's all kinds of names out there, and there's all different reasons why they show up and when they show up. But if you remember nothing else about retractions, no matter how you describe them, they're only one thing, and that's bad. So when those are apparent, the child's obviously in some degree of distress and or respiratory failure. So we need to get on this quicker than later and obviously give them that assistance so that this doesn't progress into a cardiac arrest, which it very well could. If you look at him also, you can see that he is staring kind of blankly off into space. His nasal passages are flared out. His mouth is wide open, and he's struggling. So there's obviously some major issues going on with him. This is an example of modeling. Now, modeling in and of itself, typically, and I just say that with kind of an asterisk because it can happen anywhere, but typically you'll start to see it in the lower extremities first, only because the simple fact of gravity just pulls volume down. Now, what's happening here is that because of this child's low output, the cells, the tissue in those lower extremities are just not being circulated. When they're not circulated, they do something about it, and they release a chemical called histamine, which dilates the blood vessels in an effort to try and get more circulation and get them fed, and then let them get rid of their waste products. In this case here, what it actually does is just exacerbates the problem, because now if you take that capillary that's one cell layer thick and has maybe a less than a millimeter of distance between each cell, now you dilate that capillary, now that distance between those cells maybe becomes 2 millimeters or 3 millimeters or whatever. So fluid now just leaks out into that tissue, and that's what you see here is just basically stagnant blood flow in that tissue that's not doing them any good. Now, here's the caveat with this. You can resuscitate this patient, and they can be perfectly fine, and this still may be there. Because remember, it's just residual volume. It's not going to get automatically sucked back up into their system. So it may be there for a few hours or maybe even a day after the fact in some rare cases. So don't worry so much about that. Worry more about, did that patient's mental status come back around? Did their heart rate improve? Obviously, are they breathing on their own? Are they looking better? And then you got this guy, you know, ain't nothing wrong with him. He's mentally intact. He's just going to knock your block off. So I'll take these kids any day and twice on Sunday, only because there's really not much of a problem here. There may be some other issues, anger issues maybe, but other than that, cardiac and respiratory wise, yeah, he's pretty intact. So we're not going to worry about him too much. So just some things to think about as far as when we look at these patients. Obviously, those signs of distress, those changes in color, that alteration of appearance, you know, all those things can be a precursor to these cardiac arrests. And obviously, the sooner that we act on these and improve them, the less likely they are to go into cardiac arrest. So let's look at the second thing. Second thing is that kids that get bradycardic is not a good thing. Now, that being said, you've got to be able to determine by age what's bradycardia for a particular child. And bradycardia for a 2-year-old is not the same as a 10-year-old or an 18-year-old, for example. And you can see that here, which is always nice to have some kind of a cheat sheet with you. And I would imagine a lot of you out there that work the streets probably have something either in your truck or on your person or both, when you go on shift. If not, I would get something, only because if nothing else, if you have it on you, you'll never need it. Okay, it kind of wards off evil spirits. That being said, you'll be able to tell in a lot of cases if they are bradycardic, because that low output is going to produce a lot of those signs and symptoms that we just kind of showed you in those previous slides. Now, that being said, the number one cause of cardiac arrest, and we talked about the two big ones, well, hypoxia is the biggest one. And however that happens, whether it's an asthma attack, whether it's a foreign body, whether it's upper airway swelling from some type of disease process or a inhalation of hot gas, the list goes on and on. Whatever the case may be, when a child gets hypoxic, their heart is going relatively quickly, and it needs that constant supply to meet that demand. If that supply is depleted, well, the demand gets worse, but the heart can't beat as fast as it should. And when it stops pumping as fast as it should, that output decreases. When the output decreases, perfusion diminishes, not only to the brain, but to other parts of the body. And you start to see the modeling, you start to see the changes in mental status, and you start to see those other complications start to set in. So going back and kind of correlating what we just talked about, when a child's in respiratory distress, these are some of the things you will probably pick up on. And there is some noticeable work of breathing that's been increased. I mean, it goes without saying. You look at this child, whether you've seen them for the first time or the 10th time, you can look at them and say, that ain't right. The key is that at least at this point still, they're compensating. Remember, kids compensate like crazy. They will compensate until their very last moment. And then when they crash hard. So their level of consciousness, they're able to keep that perfusion going to the brain relatively longer than in comparison to an adult. But they do that because their heart rate and their respiratory rate kicks up, and they do whatever they can to make as large an airway as possible to get as much volume of air in and get it circulated. So you'll see things like nasal flaring. And that may be the only thing that you're picking up on initially, but that's abnormal. It should not be happening. You may see any number of those retractions kind of mentioned in some of those in just previous slides. There may be a degree, of head bobbing. And what that is, we've all done it. We just didn't realize we're doing it. These kids are just kind of doing it constantly with each breath. And this time of year when it's so cold and you get a runny nose, decide not to blow your nose, you decide to kind of suck it back in. Well, inadvertently, if you try to do that, your head's kind of cocking back real quickly, just to give you a little extra force, if you will. These kids are constantly doing that. So with every breath, you'll see their head kind of bobbing back with their ventilation. And that's just, again, an effort to bring more air in. Grunting is nothing more than them trying to keep their lower airways open. So if they have some kind of reactive airway disease like asthma, or they got a pneumonia, bronchitis, bronchiolitis, what have you, they may be constantly doing this, trying to keep those lower airways open so they can ventilate. And then lastly in here, and there are many more signs and symptoms, these are kind of the big ones. If they're in distress, they're probably going to have some change in skin color. But the good thing is that when we oxygenate them or ventilate them or both, whatever is necessary, their color tends to improve pretty quickly, right? And if they are somewhat getting a little bit low with their heart rate, it tends to come back up pretty quickly. But here they're compensating, so we don't see a lot of bradycardia yet. Where we see it is if this respiratory distress prolongs itself, right? Now, again, between the ages, who's to say how much time that takes? It could be a couple of minutes, it could be longer. But whatever the case may be, if that respiratory distress is in place and it's not corrected in a timely manner, then what starts to happen is the child starts becoming hypoxemic, right? Their levels of oxygen in their blood start becoming less and less, either because they can't ventilate, they're not oxygenating, or both. The other thing is that as their brain gets tired, well, their ventilatory rate's going to start to slow down, and as it does, they're going to start retaining carbon dioxide too. Once they start doing that, now it starts throwing off their acid-base balance in their blood, right? And now they become what's known as acidotic. But again, this can be fixed with us ventilating the child properly, but we have to get there to do that. In the meantime, what starts to happen is that now that brain is getting irritated, right? It's getting hypoxic because either A, the heart's hypoxic and it's not pushing the blood up to the brain like it should, and or B, whatever amount of oxygen is in the blood is still insufficient, even though it may be reaching the brain. So either one of those two combinations Now what's happening is that, well, now you're going to get that child who has this mentation that's somewhat altered, and now this child starts becoming irritable. This is the child that now has that inconsolability. This is that child with that high-pitched cry, for example, so on and so forth. At this point, the tractions will still probably be there to some degree. They may be getting tired, so you might see them start to disappear and give you a false sense of security. That being what it is, that's all it is that the child's getting tired. That should really alarm you that really we need to intervene pretty quickly here. Their heart rate starts to slow down. Okay, and bradycardia is always an ominous sign of hypoxia. So if that's the case, we need to get them oxygenated and ventilated. Color starts getting worse, muscle tone starts getting worse because now again they've lost that nervous system control over that skeletal muscle. The brain's starting to shut itself down. Their breathing starts to slow down because the brainstem is starting to become affected, and its output just says, well, you're not going to give me oxygen, I'm not going to do my job. And so it stops firing as quickly down to the diaphragm and the intercostals as it used to. The child's rate slows down. As their rate slows down, the amount of oxygen they bring in decreases. As that amount of oxygen decreases, well, the more hypoxic and hypoxemic they get. Brain gets worse, heart gets worse, and now it becomes this downward spiral down the drain, just becoming a snowball effect to the point where eventually, when that output is poor enough, now there's just not enough going around to circulate minimally, and this is when the child becomes hypotensive and things start to get really, really bad. To the point where if they're in failure, right, we really need to act quickly because it may not be a matter of if, it's when they're going to go into not only respiratory arrest, but also cardiac arrest. Right? And a respiratory cause is a very common one with these kids that do go into cardiac arrest. Obviously, if they come to this state here, they're not responsive, they're apneic, their heart rate is very slow, probably not palpable, maybe even asystolic in this case, and a loss of muscle tone and so on and so forth. So this is where now we're BLSing, ALSing this child, and hopefully we're there sooner than later, and we still can salvage these kids. The problem is that they are now in a catastrophic event, and statistics are against them, so we really got to work hard and be very efficient in trying to resuscitate these children at this point. Now, as I said, the respiratory causes behind that bradycardia are usually numerous at best. There could be a combination of these things we see here. It could be upper and lower airway. It may be just one or the other. But whatever they are, sometimes we're also trying to reverse the consequences of these disease processes along with BLS or ALS interventions. So you've got to keep those in mind when we're trying to resuscitate this child. All right. So this just sounds ominous. I know it's not the best thing you probably want to hear on a Saturday afternoon, but there are some good things. And the good thing is that even though there is sometimes no warning, the good thing is that most of these kids that go down in acute situations like this, there's a lot of people around, right? And I'll talk about that here in just a second. So they do have a chance. There are basically, there's numerous different ways cardiovascular wise they could end up in this scenario. But when there is no warning, it tends to be one of these two big things. One, it's an inherited issue. It's a genetic thing. Okay. So some of these kids have what are called cardiomyopathies. Most of the caregivers already know this. They've been diagnosed with it, and they have these deficiencies in their heart, especially on the left side, that can cause them to go into cardiac arrest and cause, obviously a lot of problems. But these are also things that they're being treated for, and the parents and the caregivers know this. One thing that they may not be aware of is what's called long QT syndrome. And this would be, again, a genetic defect. There's various forms of this I'll talk about in just a little bit, that you may be the first person that actually discovers it. And at the BLS level, you may not have the diagnostics that do it, but at the ALS level, it's very easy to see this. I'll tell you that in just a little bit. The other thing is what's called commotio cordis. You may have heard this term before, but this tends to happen, as I said, usually with a lot of people around. And the only reason is because this tends to happen at some kind of sporting event, athletic event, even though it can be an isolated case that there's nobody around as well. But we'll talk about that too. All right, so let's look at the long QT first. This in and of itself is a talk we could talk about for an hour. But to get the gist of it, basically what goes on here is that it being a genetic defect, it's what's called a channelopathy. What does that mean? Well, your electrolytes that basically allow your nerves and your muscles and everything else to function properly, the electrolytes have to be able to go back across the cell membrane in a certain pattern, in a certain order. If those channels don't open and close in a rhythmic pattern, it screws that whole thing up and it causes a malfunction in the nervous system or the muscle or both. So with this long QT syndrome, part of those channels are thrown out of whack. So the rhythm itself is thrown out of whack, and as a result, can throw your patient out of whack. All right. The other thing could be is that you have not a genetic component, but what you have is someone that is just low on these various electrolytes. Potassium, calcium, and magnesium tend to be the most common culprits, and these could be, again, anything from poor diet to other disease processes, to dehydration, to any issues with their kidneys. And again, the list goes on and on. So there may be something that we discover on scene when we're assessing this patient or we ask about a history. Sometimes we don't pick it up until well past the point. Either way, there won't be a whole lot that we can do about it, but to gather as much information as possible is going to be a benefit once we get them to the hospital. All right, so let's look at, when we're talking about the genetic component here, these channelopathies, they basically have broken it down, they being the experts, into 3 different types. And these are all different channel problems, and they all present differently. The first one, which is called LQT1, okay, long QT syndrome 1, tends to be a common presentation when that child's under stress, whether it's, athletically, cardiovascular wise, something. And one of the most common things that are seen with this is the child is swimming, among other things. The stress of just swimming in and of itself has a lot of cardiovascular benefits, but in this case, if they have this version of it, it tends to be a detriment. Now, that's already bad enough, but of course now what do we got on top of this is that if it happens in the water, now we're also dealing with the consequences of a drowning, and that may just make the bad situation worse, and sometimes it does. Long QT2 tends to happen when a patient gets startled. So whether it's a loud bang, whether it's someone, comes up behind them because they're playing their video games on the computer and they've got their headset on and they're really into it, and someone comes up and taps them on the shoulder, maybe it's mom telling them that, dinner's ready. So they kind of get that, and then the next thing they know, they collapse right in the bed. And the parents are like, quit screwing around, and they go to shake them and they don't wake up. So that could be the precipitating event and part of the history that you get with some of those people. The third one is the hardest of all, because what tends to happen is that the child goes to bed, they were fine, they were, just perfect. There was nothing wrong with them, but they never wake up. So they die in their sleep at some point. It could be a minute after that they went to sleep, or it could be a minute before they woke up or were supposed to wake up. There's no rhyme or reason to it, but it again tends to be a common thing, and it tends to happen while they were sleeping. So either way, in most of these cases, you're going to have some further complications, but when it comes down to it, the child's still going to be in cardiac arrest from that long QT syndrome. Now, what else can cause this? Is, like I said, they could be a consequence of other things, and this being that they're being treated for other medical conditions. These medications, this is just a partial list. If you go and Google long QT syndrome medications, you'll get a list of like, I don't know, a couple hundred. These are some of the more common ones that we see in the pre-hospital setting, and some of them are for respiratory ailments, some are for mental health issues, some are for nausea and vomiting, some are simply just, again, like Benadryl, for a lot of different things. But they all can have a chemical effect on the electrical system in the heart, which can prolong the QT interval. And really what that does is, again, it makes that patient more vulnerable to a cardiac arrest. So this might be something that we pick up on. Now, how do we know? Just by looking at the monitor. And this is more for the ALS people out there. Look at the top of your picture on your 12 leads, right? It's going to tell you. If you look at it, there's a reading that's QT, and then there's one that says QTC. All you got to look for is the one that says QTC, right? It's the QT interval corrected. So it's making up for the differences in heart rate and so on and so forth. But if it's anything typically over about a 0.44, that's an indication of long QT. And like I said, you might be that first person that comes along and actually sees it and notices it, and the parents have no idea, because most people that have it never get diagnosed until a catastrophic event like this actually occurs. So one of those things might be this. Right? If they have long QT syndrome already, they have a longer vulnerable period where they can have the disturbance. And as a result, they may go down from what's called commotio cordis. And what this ends up being is, again, what you see here is a instantaneous cardiac arrest by a blow to the chest, whether it's a punch, a kick, getting hit with a ball, getting tackled. I mean, it's all different kinds of possibilities, but it's at a precise moment in the cardiac cycle that causes it to go haywire. And vast majority of these kids, 99% of these kids, don't have any history of heart disease. They've not been diagnosed with anything. This is the very first thing that actually pops up. Now, kids without long QT can get this as well, but ones that have it, they're more predisposed to it because they've got a wider window, if you will, of opportunity in the electrical system to have it malfunction. Now, why does it tend to happen in this age group? Tends to happen a little bit more in here because, again, they're younger. Their reflexes are a little bit slower, so they tend to get hit in the chest a little more often because they just don't stop the ball. They don't get out of the way or whatever the case may be. Their chest wall, their bones, the rib cage is much more pliable compared to ours. Okay? The bones are a little bit more flexible because they're a little bit more cartilage than they are actually solid bone. So that causes a problem where you just don't get that bounce off effect. And their fat and their muscle mass are proportionally less as well. Now, yes, do we have a lot of chubby 6-year-olds? Yeah, probably somewhere you will. But average, no, they don't compared to us. So they don't have the insulation, they don't have the ability to absorb that energy as well. Plus the fact that their chest gives a little bit more and they're more likely to get hit. Yeah, this could set them up for this event here. So here's kind of how it happens. And basically what we've got here is a scenario. Let's say we'll just take a line drive off a bat. And the child that doesn't react very quickly, doesn't get their glove up fast enough, gets hit in the chest at the right spot. And I'm going to show you the spots here in just a minute. Now, as you'll see here, the velocity doesn't have to be all that great. Anywhere between like 30, 40 miles an hour is all it takes. And when the ball, in this case, strikes, okay, what it does is that it compresses the chest, okay, it compresses up against the heart. And unfortunately, where this energy is delivered is very precise, and it also hits in a vulnerable period in their cardiac cycle. Right? So as I said, kids without long QT could get this, but kids that have long QT, their vulnerable period is much longer because of that genetic defect. So it hits in that weak spot, if you will, the Achilles heel of that cardiac cycle. And as you see in the very last part over here on the right-hand side of the picture, it literally just kind of stretches out the tissue and opens up, as a result, channels that were closed just from that stretch. Now, what tends to happen in this case is you get a massive influx of sodium and a massive outflux of potassium, and it stuns the heart. It locks up that muscle. And as a result, what happens is that, well, now that child takes about 1 or 2 steps. The heart is fibrillating at this point because the electrical system has been all thrown off kilter and the muscle can't contract, so it just starts to shiver, and your patient goes down because there's no output, because there's no contraction, and they're in cardiac arrest. Right? Now, as I said, where this tends to happen a lot is usually at some kind of event. So there is more than likely somebody in that crowd or on the sidelines that's going to be able to at least start BLS before we show up, and hopefully that's going to give that child a chance. Even more so, it may be that there's an AED on site and they may actually use it before you get there. All you may be doing is just asking if that child, parents, if they want to go to the hospital or not, because the child's already awake and they're already back and oriented before we even show up, which is the ideal scenario, obviously. All right, so you can see the spots on here where most of the hits tend to occur that cause this. And as I said, it could be any type of pitch thrown, batted ball, hockey puck, lacrosse ball, getting speared with a helmet if they're playing football, or simply just getting punched in the right spot at the right time. Kids that are sparring as far as boxing or judo, or I don't think they hit really in judo, but karate. any of those contact type of sports with a fist, well, there you go. And as a result, down they go, and hopefully they're resuscitated relatively quickly. As I said, doesn't take a whole lot of speed. It's just more with that speed is where and when that impact actually occurs. All right. So, well, what's next? Well, the next thing is talking a little bit about epinephrine. And you've probably heard some controversies about, well, we have a shortage, or well, epinephrine probably isn't as good in some cases, or we should probably not give it right away because it can have residual effects and so on and so forth. And all these studies probably have some validity, but in the case of kids, yeah, you need something to jumpstart that battery, and this is the best thing to do it. And delaying that treatment has been shown in numerous studies that it's nothing but bad for these kids that are in cardiac arrest. Case in point, one study here that I found, that are many out there, that a delay in the administration of the first epinephrine dose was actually associated with very poor outcomes. Now, what they did here, this was actually in hospital. So the code card was probably not that far away. The response time was minimal compared to ours. But when you look at the difference in the first minute, right, you can see that if that epinephrine was there, if it was given, ideally, most of these kids are already in the hospital. They probably had vascular access and things like that. Even if not, at least maybe giving it somehow intramuscular, whatever the case may be, you can see that at best it was around maybe 37, 38%. But even 1 minute later, okay, 1 minute delay, look how much the survivability drops off. I mean, half, easily cut in half. And then when you get down to about 5 minutes, it's cut down in half again. So you think about your average response times from where you guys live. And the key is that, well, A, the child has to go down, B, someone has to find it, C, they got to call us, D, we got to respond, and E, we got to show up. So all that time put together, we're well into this downward trend here that we don't have time to be messing around delaying it any more than what it's already been delayed, if it hasn't been given already. And in most cases that we're going to see out of the hospital, it hasn't been, because nobody's got it, right? Same thing here. Talking about not only survivability, but now we also look at even being able to walk out of the hospital neurologically intact. And even with a 5 minute delay, which is probably very typical for a lot of us just to get there, it's cut down almost again in half just because of that. So the point is that when you get there and when you have it available, and I know a lot of you out there are probably BLS providers and don't have access to it, but this is why you want ALS coming as soon as possible, or you want to, in some cases, perhaps go against what I'm going to talk about a little bit later on. And yes, you want to get that patient off the scene. You want to get them going towards ALS because you want that intercept and you want that epinephrine as soon as possible, because the statistics, obviously, in this case, are well against them. One more study to throw at you here. And this comes from, I believe this was out of Florida. And what they found here, and you can see them on the conclusion, is that even though epinephrine was obviously indicated in most of these cases, most of it was not given, okay, or the amount that was given was not very, very timely. And so in about 35% of the pediatric cases, they had a very substantially lower amount of epinephrine that was actually administered to that patient. Because what happened? Well, in a lot of these cases, earlier cases, these people were scooping and running, and they never had access and they never got it in before they got to the hospital, or they never thought about it because, well, it was a kid, and people start to lose their minds when they're in cardiac arrest with a child. But this is where your teamwork needs to come into place, and you need to have that point person kind of directing traffic, saying, hey, we haven't given this yet. We need to get on it. We need to get access. We need to get going here. We need to have that epinephrine in as soon as possible. Which leads me to this, and then the next point, which is all of y'all out here can do this, right? And it seems kind of trivial because it's like, well, yeah, of course we will. But this gets missed. Sometimes we do this actually too well because we're all jacked up. We're compressing way too fast. We're not letting that chest recoil. We're ventilating way too fast. We're too concerned about getting a tube in versus just, doing it with a simple oral or nasal airway and a BVM. So we want to make sure with these kids that the basics get covered, because the basics are going to bring the majority of these kids back if we bring them back at all, right? Good, solid BLS, CPR, AED management, and basic airway is what most of these kids need right off the bat. Now, to make it more efficient, and some of you may already have this in your system, and if not, you may look at kind of subscribing to this, is what's called the pit crew mentality as far as CPR. And it's similar to what you see if you watch NASCAR or anything similar to that. Everybody's got a job. One person's directing traffic, one person does the AED, one person's doing compressions, one person's ventilating, one person's giving med, blah, 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 however you guys disseminate the information. And these particular services that you see here were kind of the first ones to really make this part of the protocol. And just by doing this, just that simple change and making it more efficient so that everybody knew what they were doing the second they showed up on scene, these, not only the resuscitation rates, but the survivability of these kids went through the roof. All right. And it was just something, again, that simple that made a big difference. So this is what we want to do, obviously. One is you want to make sure that at least you're on that chest 80% of the time. How do we do that? You minimize that time between when you stop compressions and you give ventilations. Should be no more than 5-10 seconds tops. If you're doing pulse checks, probably less than 5 seconds in most cases. You want to make sure you have an adequate compression rate. Now, with some of the younger kids, God forbid, like the infants and the toddlers, it'll be a little bit faster than what you see here just because of their age, but you want it at an age-appropriate rate. The other thing is that you want to make sure you're getting it deep enough. Now, sometimes this whole 1/3 of the anterior posterior dimension of the chest, you're like, oh, what the heck is that? How are you going to know if you're getting an adequate compression? Is have someone either grab the femoral pulse, grab the carotid pulse, brachial pulse, whatever is available, and do they feel a pulse wave every time you're compressing? If they do, then you're pressing enough. If they don't, then either A, they need to readjust their hands, or B, if they're in the right spot, you need to press harder. Simple as that. The other thing is, which is probably even more important, which I know you've all heard before, is you've got to let that chest recoil. It's, yes, important to press deep enough so that you push the blood forward, but it's even more important that you let that chest come all the way back up so that that heart has a chance to refill as best as possible. If you start jackhammering on the chest and the rate gets going too fast, your refill time is going to be diminished, and as a result, you're just not pushing as much blood with every subsequent compression. And that's just not going to do them good as far as perfusion goes, and obviously resuscitation. Lastly, watch the ventilations. Most of the time, it's around 10 to 12, because that's really not an oxygenation issue. You're BVM in this child, or if you've got some kind of a supraglottic type of airway, or if you've got an endotracheal tube in place, they're getting good ventilation for the most part, and they're getting good oxygenation with every ventilation you're providing. So that's not the issue. The issue is more with, let's get it circulated around. If you ventilate too fast, what'll start to happen is that you'll start to increase the pressure inside their chest. And that does is that just decreases the ability for them to have their heart have a sufficient output. So we don't want that to happen. We don't want to fight against ourselves. So keep those rates on the DL, right around 10, 12-ish, give or take. And obviously, if it gets to the point where you do have that iGel or King or whatever that you put in, or endotracheal tube, if your advanced providers do that, now it's basically compressions and one breath every 6 to 8 seconds. So again, we keep it continuous as best we can. All right, so that goes to this, right? I mentioned it before. People hear this and they're like, are you out of your freaking mind? Why on God's green earth would I stay on scene with a cardiac arrest with a child? Well, it kind of goes back to a little bit about what I mentioned previously, is it prevents a lot of these delays in these BLS and ALS interventions. If you just scoop and run, remember, these kids have been down for who knows how long before we even show up. Now we're going to delay it even more, even if it's a minute or two, by getting an airway established or getting compression started, or doing anything that's going to be good for that child. Even a minute or two might be that last minute or two that they had left. And so now we're just basically running through this, and it's not going to be a positive outcome. Again, a lot of studies have looked at this. And one of them that you saw here, you see in this screen here, was done back in 2015. And it was, again, looking at the interventions associated with survival that were good, that allow for these kids to actually be resuscitated and have a decent outcome from an out-of-hospital cardiac arrest. So it was a pretty big study. They had close to 2,300 patients ranging in various ages like you see here, and these were all non-trauma cardiac arrests. That was part of the criteria. What they were hypothesizing was that, okay, the more time you spend on scene, doing good BLS, getting these interventions, getting epinephrine on board, getting them ventilated, doing those things that we have to do, looking for the reversal of those causes and so on and so forth, their outcome's going to be better. Kind of makes sense, but we've got to prove it. Well, what they found, among other things, is that there's kind of a sweet spot. Is that how long should you stay on scene? Now, your medical direction may have already established this for you, and part of it might stem from studies like this. It ranges, you know. The thing was this thing at least 10 and probably no more than about 30, 35 minutes. Now, there are some services on the East Coast especially that they go 40, 45 minutes because that's what their medical director wants, and they're still getting decent outcomes. There are some places that say, you know, 10 and then you're out. Here, we're right about 20 minutes. Most of our county protocols will require that. So after about 35 minutes, they found regardless, in most cases, that if the child was going to be resuscitated, it was going to happen before then, and most of these kids usually didn't improve and sometimes actually got worse. Now, that being said, being on scene for at least 10 minutes, all these things that we've been talking about got done, right? They were actually to stop, take a breath, assess the scenario, see what was going on, and again, started good BLS, got the AED on or got the defibrillation pads on, got the monitor attached, got the IV started or the IOs, got the airways established, got these kids ventilated, got the medications in, right? And on top of anything else, if nothing else, because I know you all done this, and if not, stay in this business long enough, you will, that running a code in the back of a moving ambulance is terrible. There's no room. You are on top of one another. There's just no space to operate. Okay. If you're at someone's residence or if you're at a park or, you know, God forbid, a school or whatever the case may be, if nothing else, staying on scene, you've got more room to operate and you've got more room to set up and you've got more room to do this efficient pit crew type of CPR if that's what you're going to institute. The problem is that obviously there's going to be a lot of bystanders, family members, whomever, in a lot of these cases that are going to be saying, go, go, go. Right? You may need another person that basically is just kind of talking to them and telling them why you're staying on scene. It's actually a benefit. It is not a detriment in the vast majority of these cases. Right? Now, what they come to find out from this particular study is that the infants didn't do very well. Kind of goes without saying, as terrible as it is. But again, they're very primal. They don't have a lot of reserves, and when they go down, they don't tend to come back very well. But as the children were older, they tended to do a lot better. And of course, the other reason that led to the infants not doing very well is because they were an infant. So their scene time was much shorter because everybody either panicked or ran or both. Right? And as a result, they didn't maybe get the interventions they should have. Here was another one that was done. And this one was actually very significant. I'm going to show you the numbers here in just a second. But what they did is made just these small amounts of changes here. Okay, what they did is that they added in supraglottic airways. You know, they added in I-gels, which they didn't have before, and used that. They added in controlling the ventilation rates. They added in IOs and doing them earlier rather than worrying about doing IV access. They added in this pit crew type of approach that they didn't have before. So before all that addition, if you look at the bottom of this particular graph here, in between 2012 and 2013, they had 38 pediatric cardiac arrests. They had 2 resuscitations, but no survivors. So medical direction sees this. They started coming up with these ideas. They started looking at the evidence and the research, and they thought, you know what, we're not doing the right thing. And so they retrained their staff. They added in those changes that I just showed you. And then in that graph here, you see between 2014, 2015, right? In that year's period, they had 56 pediatric cardiac arrests, right? Out of those 56, 17 were resuscitated, which that in of itself, statistically, is just way off the charts. But of those 17, all right, 13 of them actually survived and walked out or were taken out of the hospital neurologically intact, just by simple changes like staying on scene, doing the meds, getting the good BLS and ALS instituted, and having time to do it. Right? Like I said, the simple stuff, the basic stuff saves these kids more often than not. And the evidence right here, there are other studies like this that are out there that you can find that show the same thing, that are probably a little more recent, but it's the same scenarios, you know. And so it's a good thing. If you're not doing it, might be something to think about doing. Obviously, some of you that have very long transport times where you're at, I get it. You know, we have some areas here in Ohio that, yeah, they're 20, 30, 40-minute transport times simply because they're either up in the hills in Southeast Ohio here, or they're out in the middle of nowhere in the rural farmland, and there's just nothing around. Now, this may also be that consideration where you think about air support. You know, call that helicopter. It's a cardiac arrest, and you're thinking, well, helicopters are for, you know, really severe, trauma cases and things like that. Well, yeah, they are. Okay, and believe me, the medical crews that are on those live for trauma. But if they can be a benefit by reducing that scene time and obviously bringing a little bit more advanced care, if you've got them stabilized in the field, there's less chance that they're not going to relapse, and obviously they may be surviving relatively much more than if not. So it's stuff to consider. Okay, the last thing that we're going to talk about. So we've talked about all the good things and, you know, things to look for, and obviously reasons behind why we're doing some different things with these kids. But there are times where you may just have that traumatic arrest. You know, and when that happens, there gets to be a point that, unfortunately, sometimes it's just time to knock it off. Now, as I'm sure you're well aware, you probably have some protocol, and if not, it may come down the line that there's a termination protocol in your particular area. If you don't have one, that's okay. Then it's usually a med control issue. But in certain cases, there may still be a reason to keep going. And especially with kids, you know, whether you think that there's no chance or that there is some sort of chance, yeah, you're going to keep going because it's a kid. You know, we do that. It's just natural, especially if you're a parent. You're going to go all day and, you know, into the night if you have to work on this child because it's just human nature. And there's nothing wrong with that. Even with that traumatic out of hospital cardiac arrest, right, there are times where we know statistically the child's not going to make it, but we still should give them that chance. And here's just some of those things. One is that it was witnessed. And before they arrested, and probably relatively soon before you got there, they were still alive-ish. You know, there were still signs of life, and or CPR was started on scene, and it's in progress when you show up. So we want to make an effort to continue that care and give them that chance. Another time with a cardiac arrest, which is related to trauma, is that you've got some kind of mechanism that really doesn't correlate with a traumatic cardiac arrest. What I'm getting at is that you say you have that child who falls off a skateboard and rolls into the grass and doesn't really hit their head. In fact, they even got a helmet on. They've got all the pads on. They didn't fall very far. They weren't going very fast, but yet someone goes over and tries to nudge them on the grass and they're dead. So did they have some other event? Perhaps it looks like a trauma. Okay, it was a mechanism that you're being explained, but yet it really wasn't that major mechanism that we would expect to put them in cardiac arrest in the first place. Another one is a little voice in the back of your head. Okay? We all got it, just like we got spidey sense. You know, something just doesn't make sense. Something says, you know what, I'm not sure. So work them. You know, if there's a doubt, we'll work them, and there's nothing wrong with that. You may be told sooner than later to stop, but give them that chance. And lastly, you get at this traumatic arrest, and you've got two significant precipitating events. One would be is that it was a drowning. So again, we go back to that child with long QT1, and maybe they have that arrest in the water, and maybe that's part of the scenario that we're dealing with. And or two is a lightning strike. Lightning strike tends to cause disruption of the nervous system, but their nervous system tends to come back. The problem is that it comes back at the heart before it usually comes back with the brain. and they suffer what's called a secondary arrest. And that goes with any lightning strike, but especially with kids. Yeah, they look like they're dead, and for all intents and purposes, they kind of are, but they can be resuscitated without usually a whole lot of intervention. So we're going to give them that benefit of the doubt in that case as well. All right. So when we do so, and we've got those possibilities, they tend to still be resuscitated and they survive with decent neurological outcomes if these things are in place. And it obviously goes without saying. The sooner that CPR and the sooner that we resuscitate them, that's going to improve their chances. Kind of a funny thing, as much as I kind of harped down with epinephrine, in the case of trauma, right, it didn't really make a difference. It didn't hurt, but in a lot of cases, it didn't help. And remember, the reason that they're down because of trauma is because of some kind of anatomical issue. So epinephrine may be of some benefit, but it's not going to be the most thing. Good BLS and obviously looking for the cause will be much more important in these cases here. However, as I said, there are times where it's like, no. And what we kind of associate that with is what's called a sign of futility. Now, the primary sign is basically an injury that's incompatible with life, or obviously they've been dead for a very long time. So you see things like you see here with, decapitations and traumatic amputations and, chest injuries where, there's massive damage done and things like that, where you look there and it's like, yeah, there is nothing that's going to bring this child back no matter what we do. Anatomically, the disruption is just so catastrophic. It's like, okay, we're not going to start, or we're going to stop. The traumatic arrest, though, with a secondary sign would be something, as I said, where they've been probably down for a long period of time. Whether they're pooling their blood, they're rigorous, obviously signs of decomposition. These are the Mr. Obvious signs that say, yeah, secondary to trauma, obviously there's no reason to start. And or if you have a drowning or a lightning strike victim and they have either one of those primary or secondary signs like you see here, then even though we talked about how with drowning or lightning strikes we should give them a chance, if they have these signs of futility, well, then again, it goes without saying, well, there's not really a reason to get started. It's, again, futile. So what do we look at as far as the time? Well, we talked about that time frame with the one that gave you that sweet spot between like 10 and 35 minutes. But you get that traumatic arrest, it's been unwitnessed, and that's kind of the key here. And or you've been doing this for well over a half an hour and you're not getting any kind of positive sign or symptom. This may be one of those things where you're going to have a protocol that's going to tell you that it's time, even though we're done everything, and maybe we've got another drug in the box, maybe we've got another set of hands, we can try another round of CPR. The law of averages at this point are against them. They usually have poor outcome because they've been down for so long. Even with our good CPR, remember, even at your best, you're only replicating about a third of the normal output that this child has. So over a period of time, just that amount of damage and toxins and everything else are going to backbuild in their system, and that is going to keep them down because we just can't get rid of them because we haven't restored their heartbeat. A lot of them also have been associated a lot with head injuries. So that in of itself is bad, but then you add that on top of the long downtime, there's just really nothing to do at that point. So at that moment, what do we decide to do is we can call that control or we go by our protocol. And obviously at that point, it may be time to stop. Okay. So that being said, that's it. So I hope that was beneficial for you. And if you have any questions or anything that I can kind of work through, we got a couple of minutes here. Give me a shout here and we'll see what we can do.
So Chris, one of the questions you talked about lightning strikes, what about electrocution in general as being a patient you give a longer resuscitation attempt to?
Yeah. The reason being is because what tends to happen when they get, say, struck by lightning or electrocuted is that it stuns the whole electrical system in the nervous system in the body. What tends to happen, especially more with lightning strikes because of that impact with the direct strike, is that it's more of a stunning effect. And what tends to happen is that the brainstem does not react as quickly as the heart does. So they'll go into arrest, but then the heart basically kind of shakes the cobwebs loose and starts beating again. Problem is that as it starts doing so, the brain stem is still knocked out. So they're not breathing, but the heart gets going. And what the heart does is uses up all the oxygen that's in the bloodstream. And if they are not breathing by the time that occurs, then the heart rearrests because of that lack of oxygen. And even if we do start ventilating for them or they start breathing on their own, that re-arrest, that secondary cardiac arrest, is usually something they don't recover from. So the key is to give them good BLS and get them ventilated as soon as possible, because eventually that brainstem probably will come around. It's just a matter of how long it'll take, but it will take longer than the heart. And we don't want that secondary arrest to occur. So there's a term out there which is called reverse triage. So if you get like a multiple casualty incident, and all because of a lightning strike, the dead ones, right, the black tags we would normally do, go after them first, because you're likely to get a resuscitation in that case. And that's kind of the one asterisk to the rule of normal triage.
All right, there were some other questions earlier talking about on-scene times with pediatric cardiac arrests. So BLS agency, where they're BLS only, stay on scene longer, transport immediately. What would you recommend?
Staying, well, again, they have to follow their own protocol, but staying on scene longer, getting more stuff done, especially if there is ALS on the way, is only going to be a benefit for that child. But if they're only a BLS organization and there's no ALS available for quite some time, then I would still recommend at least the minimum, 10, maybe 15 minutes on scene, and then pick up and go, because by then we have gotten everything, at least as far as the basics, covered, and we're giving that patient the best chance.
All right, just scanning through here to see if there's any other questions we missed. I think that was it. Any last questions for Chris before we give him a break? He's going to come back and present to us again here in about 15 minutes.
And if you all have any questions, by all means, again, there's my information on the screen here. Feel free to email me and I'll be glad to get back to you.
All right, well then we will close this one up and we will see everyone back in about 15 minutes or so.